Hello students, I am Dr. D. N. Shrienitha, Assistant Professor from the Department of Public Health Dentistry from Vinayaga Mission Sankaracharya Dental College. I am here to teach you a topic about epidemiology of malocclusion. These are the contents of epidemiology of malocclusion. Today I will be teaching regarding the introduction, that is what is malocclusion and what are the unfavorable sequelae of malocclusion and classification of malocclusion, and also what are the various classification which includes the modifications and prevention of malocclusion and how you will measure the malocclusion, and conclusion and references. Coming to the introduction part, what is malocclusion? In which any deviation from the normal occlusion is called malocclusion, where the normal alignment of teeth contribute about the aesthetic and the function. We are very much concerned about the aesthetic nowadays, so occlusion plays a major role in our daily life. What are the sequelae of malocclusion? Malocclusion, what it will cause is that poor facial appearance, the risk of caries will be higher, and then predisposition to periodontal disease, that is due to malocclusion many cannot brush the teeth properly, so they get the periodontal diseases. And also due to the malocclusion there are more predisposition disturbances, that is psychological disturbances, and also risk of trauma, abnormalities of function and TMJ problems. What are the etiology of malocclusion? It is based on both local factors and general factors. Local factors is that there is anomaly in the number of teeth and also anomalies of tooth size, anomalies of tooth shape, abnormal labial frenum, premature loss, prolonged retention, delayed eruption of permanent teeth, abnormal eruptive path, ankylosis, dental caries and improper dental restorations. And what are the general factors? It is given based on the Krabbe's classification, that is hereditary, congenital and environmental, which includes both prenatal problems and postnatal. Prenatal is that trauma, maternal diet and German measles, and postnatal birth is birth injury, cerebral palsy, and also predisposing metabolic climate and disease, that is due to endocrine imbalance, metabolic imbalances, the disturbances, it is caused based on the aesthetic appearance and infectious diseases, and also dietary problems, which includes nutritional deficiency and abnormal pressuring habits. In children we get to used to know that thumb sucking habit and tongue thrusting habit and lip and nail biting and mouth breathing, and also the postures and trauma and accidents. This includes both the general factors and local factors. What is the epidemiology of malocclusion? Where the prevalence of malocclusion is higher in developed countries compared to the developing and underdeveloped countries. Indians more tend to have class 2 relationship than Africans, and also class 3 malocclusion is less prevalent in India, and malocclusion is relatively low in deciduous dentition. And coming to the unfavorable sequelae of malocclusion, that is the normal alignment of teeth, not only oral health but also it influences the overall well-being and personality of an individual, that is the correct tooth position is an important factor for aesthetic function and also overall preservation or restoration of dental teeth. And also the poor facial appearance, that is malocclusion is capable of adversely affecting the facial appearance of an individual and also risk of caries. As I previously said, the malalignment of teeth makes oral hygiene maintenance a difficult task, thereby increasing the risk of caries. And predisposition to periodontal disease. Obviously, when they don't do the oral hygiene properly, they have poor oral hygiene, which is a frequent cause of periodontal diseases. And also, when the teeth are placed in abnormal position, can be a cause for traumatic occlusion which result in periodontal tissue damage. And psychological disturbances. Malocclusion that adversely affects the appearance of a person leads to psychological disturbances, and also the person will become highly self-conscious and they turn into an introvert. Risk of trauma, where they have severely proclined teeth, they are more prone to injury, especially during playing or during the accidental fall. And abnormalities of teeth, where many malocclusion abnormalities are causing the difficulty in functioning, especially improper deglutition, defects in speech and improper respiration. And also it is causing temporomandibular joint problem, which is associated with occlusal prematurities, and debite is believed to be a cause of TMJ problems such as pain and dysfunction in the TMJ. Next, we will be seeing the classification of malocclusion. First, we will see Angle's classification, and then we will see Dweill's modification of Angle's malocclusion, and then Simon's classification, Ackermann's Prophet classification and Bennett's classification. What is the need to classify the malocclusion? First, we have to diagnose and plan the treatment plan for that particular patient, and also we should be able to visualize and understand the problem associated with the malocclusion, and also it helps in communicating the problem with the patient, and also it helps the comparison of the various malocclusion is made easy by the classification. First, we will see Angle's classification. It was given by Edward Angle in the year 1899, and also it is almost 100 years of its introduction due to the simplicity in application. And also Angle's classification was based on the mesiodistal relation of the teeth, and also it is given based on the maxillary first premolar key to the occlusion, and also it is considered to be the fixed anatomical point within the jaws, where the Angle's classification is classified into Angle's class 1, class 2 and class 3. You can see the picturization in that there is the Angle's class 1 malocclusion and Angle's class 2 division 1 and division 2, that is Angle's class 3 finally. Okay. And what are the drawbacks of Angle's classification? Although it is 100 years older, it is based on the fixed point. It is based on only the single plane, that is the anteroposterior plane. So various type of classification came into existence. First we will be seeing the Angle's class 1. If the Angle's class 1 comes to your mind, first it should be based on the buccal groove of the mandibular first permanent molar, where the mesiobuccal cusp of the maxillary first permanent molar occludes with the buccal groove of the mandibular first permanent molar. The patient may exhibit various irregularities such as crowding, spacing, rotation and missing teeth. And also the patient exhibit the normal skeletal relation, where in another cases, class 1 is based on the bimaxillary protrusion. Kindly note, so far we have seen Angle's class 1 malocclusion. It is based on the mesiobuccal cusp of the maxillary first permanent molar occludes with the buccal groove of the mandibular first permanent molar. Next, we will be seeing Angle's class 2. That is, it is characterized by the distobuccal cusp of the upper first permanent molar occludes in the buccal groove of the lower permanent molar. It is subdivided into Angle's class 2 division 1, class 2 division 1, that is proclined upper incisors with a resultant increase in overjet, where the deep incisor overbite can occur in the anterior region, where the characteristics of this occlusion is that presence of abnormal muscle activity in class 2 division 1. And also the important feature here you have to note is division 1 is referred to as lip trap, where there is a maxillary proclination. The patient will not be able to close their mouth, so they will be losing their confidence, and also they will be making their lip towards the upper incisors. So this is called as upper lip trap, where the upper lip usually hypotonic, short and fails to close to form a lip seal. Here the tongue occupies the lower posture, thereby failing to contract with the buccinator activity. And also there the unstrained buccinator activity resulting in the narrowing of the upper arch at the premolar and canine region, thereby producing a V-shaped upper arch. And also another muscle aberration is a hyperactive mendalis activity. The muscle imbalance is produced by a hyperactive buccinator and mendalis and an altered tongue position that accentuate the narrowing of the upper dental arch. Here you could see what are the various views of Angle's class 2 division 1. The picture A shows the buccal view, and also picture B shows the labial view of the Angle's class 2, that is increased overjet, and also in picture 3 it is showing that the lower view, that is increased overjet and proclination of the upper anteriors. It is in cephalometric showing the severe proclination of the upper anteriors. Next we will be seeing class 2 and division 2. Here the class 2 also exhibit a class 2 molar relationship. The classic feature of this malocclusion is the presence of lingually inclined upper central incisor and labially tipped upper lateral incisor overlapping the central incisor. And also the patient exhibit a deep anterior overbite. The lingually inclined upper centrals gives arch a squarish shape. Here the mandibular labial gingival tissue is often traumatized by the excessively tipped upper central incisor. The patient exhibit the normal perioral muscle activity in class 2 division 2. And also there is an abnormal backward path of closure may also be present due to the excessively tipped central incisor. Okay, this is the view which is showing the class 2 division 2 Okay. Next we will be seeing class 2 subdivision. Also you have to note that when a class 2 molar relation exists on one side and a class 1 relation on the other, it is referred to as class 2 subdivision. And also based on whether it is division 1 or division 2, it can be called as class 2 division 1 subdivision or class 2 division 2 subdivision. This ends the class 2 angles classification. Next we will be seeing angles class 3 malocclusion. Here the class 2 molar relation, that is the mesiobuccal cusp of the maxillary first permanent molar occluding in the interdental space between the mandibular first and second molars, that is class 2 malocclusion can be classified as true class 3 and pseudo class 3. Here we can see the clinical features. What is true class 3? It is excessively large mandible, forwardly placed mandible and also smaller than normal maxilla, retroposition maxilla and combination of all the above cases. Okay, this is the true class 2. Here we can see the clinical pictures of buccal occlusion view showing the class 3 molar relation and also anterior crossbite and also the lateral surf view of the same patient showing the class 3 malocclusion. Next we will be seeing what is pseudo class 3. It is produced by the forward movement of the mandible during the jaw closure, also called as postural or habitual class 3 malocclusion. What are the causes of class 3 malocclusion? Presence of occlusal prematurities may deflect the mandible forward in case of any premature loss of a deciduous posterius and also a child with enlarged adenoids. This is pseudo class 3. Next we will be seeing what is class 3 subdivision. As I previously said, class 2 molar relation on one side and class 1 molar relation on one side, we will be considering it as class 2. Here in this class 3 case, there is a condition characterized by a class 3 molar relation on one side and a class 1 on other side. It is considered to be a class 3 molar relation. So far we have completed the angles classification. Next, the device modification of angles malocclusion. Here they have proposed the modification which is based on class 1 into 5 types and class 3 into 3 types. First we will see what is class 1 modification based on the 5 types. Type 1, that is class 1 with bunched or crowded anterior teeth, and type 2 class 1 with protrusive maxillary incisor, and type 3 class 1 with anterior crossbite, and type 4 class 1 with posterior crossbite, where the type 5 is that the permanent molar has drifted mesially due to early extraction of second deciduous molar or second premolar. Next is class 3 modification. Here it includes 3 types, that is type 1, the upper and the lower dental arches, where it will be viewed separately, it is showing a normal alignment. And also we ask the patient to occlude and it is showing the edge to edge incisor alignment and also a forwardly moved mandibular dental arch. This includes the device modification of class 3 type 1. Type 2 is the mandibular incisors are crowded and are in a lingual relation to the maxillary incisors. The maxillary incisors are crowded and are in crossbite in relation to mandibular anteriors is type 3. This ends the device modification of the angles classification. Next we will be seeing Simon's modification. It is based on the planes, that is anteroposterior plane, transverse and in the vertical planes. Okay. First we will be seeing it is based on the anthropometric planes, that is Frankfurt horizontal plane, orbital plane and mid sagittal plane. Okay. First we will be seeing Frankfurt horizontal plane, that is where the plane is placed on the external auditory meatus to the infraorbital origin. It is based on the vertical plane. Kindly note the Frankfurt horizontal plane is based on the vertical plane, where the dental arch is closer than the normal to the Frankfurt plane. It is called as attraction. Where it is farther away, it is called as abstraction. Okay, this is the Frankfurt horizontal plane. It is seen in the vertical plane, that is Frankfurt horizontal plane. Next we will be seeing orbital plane, that is where it is perpendicular to the Frankfurt horizontal plane, drop down from the bony orbital margin directly under the pupil of the eye. And also this plane should pass through the distal third of the canine, called the Simon's law of canine. This plane is used to describe the malocclusion in a sagittal or anteroposterior direction. That is, where the dental arch it is farther from the orbital plane, it is called as protraction, and it is closer to the plane, it is called as retraction. this is the picture which is showing the orbital plane which is perpendicular to the Frankfurt horizontal plane. Next we will be seeing mid-sagittal plane. It is used to describe the malocclusion in the transverse direction, that is when it is away from the mid-sagittal plane it is called as distraction, and it is closer to the mid-sagittal plane it is called as contraction. You could see the picturization of the mid-sagittal plane. Okay. Next we will be seeing what is Bennett's classification. It is based on various causes. Here we will be seeing first class 1, it is due to local causes, and also class 2 is where the abnormal formation of the part of hole or either arch due to the developmental defects of bone, that is bony defects is seen, it is class 2, and class 3 is that abnormal relationship between the upper and lower arches and between either arch and facial contour and correlated abnormal formation of either arch. Next is the important classification, that is Ackermann-Profit system of classification. It was given in 1960. It is based on the diagrammatic representation, that is what are the salient features we will be seeing in Ackermann-Profit classification is that it shows both the transverse as well as vertical discrepancies. Okay, and also it is based on the crowding and arch asymmetry also can be evaluated by Ackermann's Profit classification. Here we could be able to see 5 major characteristics which is taken to consideration in Ackermann's Profit classification. Okay, first we will be seeing what are the transverse deviation, sagittal deviation and vertical deviation, and what are the profile and what are the intra-arch alignment. That is, a transverse deviation is that whether it is buccal, palatal, that palatal include unilateral or bilateral, dental or skeletal, and also sagittal deviation is that class 1, class 2, division 1 and division 2, class 3 it is of either dental or skeletal, and also vertical deviation is that open bite anterior, open bite posterior, deep bite anterior, collapsed bite and posterior, which includes both dental and skeletal in point of all types of deviation, and also profiles anterior divergent and posterior divergent, convex, concave and straight. It also includes ideal, crowding and spacing. This is the important Venn diagram. This carries more marks. So if you get a question that is classification of malocclusion, you should be able to write all the classification, that is angles classification, angles class 1 and angles class 2, division 1, division 2 and angles class 3, that is true class 3 and pseudo class 3. Next we have seen Simon's classification, Bennett's classification and Dwight's modification of angles classification, and finally we have seen Ackermann's Profit classification. This ends the classification of malocclusion. Next we will be seeing how we will be measuring the malocclusion. First, it is that constitute a hazard to the maintenance of oral health and interfere with the well-being of the person by adversely affecting dentofacial aesthetic, mandibular function or speech. Okay. First, what is the prevention of malocclusion? We will be able to see preventive orthodontics and interceptive orthodontics. In case of preventive, we should be able to care the deciduous dentition, where in deciduous dentition stage, we should be able to give the patient the natural space maintainers, and also we should be able to manage the ankylosed teeth, that is we should be able to diagnose it early and surgically remove at the appropriate time to permit the permanent teeth eruption, and also maintenance of quadrant wise tooth shedding time schedule, where any delay in eruption due to cyst or supernumerary teeth ankylosis or over retained teeth. Checkup for oral habit, and it should be identified earlier and educated on ill effects, and occlusal equilibration leads to deviation in the mandibular path of closure and predisposed to bruxism eliminated by the grinding, and extraction of supernumerary teeth and space maintenance. As I said, in early detection of deciduous dentition, we should give some space maintenance, that is band and loop space maintainer, crown and loop space maintainer, band and bar space maintainer, crown and bar space maintainer, and lingual arch space maintainer, transpalatal arch and transpalatal arch, and distal shoe space maintainers. Next we will be seeing interceptive orthodontics. So far we have seen preventive orthodontics. Interceptive orthodontics is that serial extraction, that is early mixed dentition, correction of developing crossbite and control of abnormal habits and space regainers and muscle exercise, and removal of soft tissue or bony barrier to eruption of teeth. Interruption of skeletal malrelation, class 2 by myofunctional appliances, Class 3 by chin cup with headgear and face mask therapy. So this ends the prevention of malocclusion. Next is levels of prevention of malocclusion, is that it is based on primary, secondary and tertiary prevention. Whether we can provide the services based on preventive services provided by the individual, services provided by the community and services provided by the professional. First, in primary prevention, we will be seeing health promotion and specific protection, where what are the services provided by the individual based on the specific protection. We should be able to identify it earlier and use of protective devices to escape the patients from the any injury, and also early diagnosis and prompt treatment, disability limitation and rehabilitation. We should be able to utilize the dental services properly. It is the services provided by the individual. Next is the services provided by the community, that is in health promotion, that is primary prevention. It includes health education, that is we should be able to educate the patient based on the services they got, and also mouth guard program and safety of school building and playgrounds to eliminate the patients from getting the injury. And secondary prevention is that prevention of dental services, and tertiary prevention is also we should be able to educate the patient and what are the dental services we provide. And services provided by the professional is that we should be able to educate the patient, and also we should be able to give the space maintenance and genetic counseling, prenatal care and parental counseling at the deciduous dentition stage when the patient is coming earlier to us. And also minor orthodontic procedures can be done at the secondary prevention level stage. And tertiary prevention is that, as I said, major orthodontic procedures and maxillofacial, fixed and removal prosthodontic, plastic surgeries and speech therapy can be done. These are the levels of prevention. You can get the question separately at levels of prevention of epidemiology of malocclusion. You should be able to write this table completely. Okay, finally conclusion. And normal alignment of teeth not only contribute to oral health but also goes a long way in improving the quality of an individual. Majorly, the malocclusion is considered with the patient, not only patient oral health, and also it destroys the patient confidence, which does not tend the patient to improve their quality of life. Next is correct tooth position is an important factor for aesthetic function and for overall preservation or restoration of dental health. While most malocclusion may not adversely affect the health of an individual, they nevertheless are capable of producing the undesirable functional and aesthetic imbalances. Okay, these are my references. So far we have seen what is a malocclusion and what are the general factors and what are the local factors, or what is the classification of malocclusion, and also what are the treatment, that is preventive treatment and interceptive orthodontic treatment, and also what are the preventions, that is levels of prevention at primary level, secondary level and tertiary level. Finally conclusion. Thank you for watching my video.